Good afternoon, everyone. Can everyone hear me? Loud and clear? Okay. I'd like to wish everyone a good afternoon, our esteemed guests, colleagues, media friends, and our live stream viewers. A warm welcome to this rather significant and timely panel discussion titled A Breath of Fresh Hope. My name is Ratika, and I'm your MC for today's session. Ladies and gentlemen, we all know lung cancer to be an ongoing concern amongst non-communicable diseases here in Malaysia. But what conventionally has been viewed as an older male concern could be very far off from the truth. There has been a staggering increase in global lung cancer rates amongst women over the last few decades, and the majority of them aren't even smokers. The causes are diverse, ranging from exposure to air pollution, family history, and many others. What is more concerning is because of the misconception that only smokers can get lung cancer, and most women who are non-smokers don't even see the signs until it is far too late. I hope this gives you a sense of the gravity of the situation that we are looking to unfold today, speaking to our esteemed guests, and also to looking into all the demand that we can provide to our viewers and everyone that we work with. This is not just a discussion, it's a call to action. And here at Roche, we are committed towards bringing more investment and awareness towards women's health and innovations to treat lung cancer in its early stages too. Now today, we are privileged to be in the company of experts who not only bring their wealth of knowledge, but also a shared commitment to turning the tide against the rising challenges in lung cancer. I'd like to give you a quick, brief introduction to our moderator and our three panel of speakers. So first we have Ms. Dipti Saraf. Dipti is the General Manager of Roche Pharmaceuticals. She is also the Vice President of the Pharmaceutical Association of Malaysia. She brings with her nearly 20 years of experience in the pharmaceutical industry in India and Thailand, and has worked across multiple disease areas, including primary care, oncology, comprehensive genomic profiling, and nephrology. In India, she has worked to establish a rural healthcare commercial model, and in Thailand, she worked with the Thai healthcare ecosystem to implement the Thai Genomics version 4.0, enabling Thai patients to have better outcomes, personalized healthcare. She is also deeply committed to building a culture that empowers decision-making while encouraging innovation and experimentation that benefit patients. In the APAC region, Dipti is deeply committed to sponsor all women's care initiatives, cancer initiatives, and is very passionate about women's healthcare and women's leadership while being a mentor to many women in the healthcare sector. A round of applause for Dipti, please. Next, we have Dr. Anand Sachinanandan. Dr. Anand graduated from the RCSI Medical School in Dublin, Ireland in 1998, and subsequently completed his postgraduate cardiothoracic specialist surgical training at leading hospitals in the UK. He's currently practicing at Sunway Medical Centre and the Subang Jaya Medical Centre. He's a highly published surgeon with special interest in thoracic conditions, especially lung cancer, and has been invited to speak at numerous national and international scientific meetings. He is the founding president of the Lung Cancer Network Malaysia, which he co-established in 2018. He's passionate to advocate for early lung cancer detection with targeted screening, and is a strong proponent of the need for a multidisciplinary team approach and multimodal therapy to provide the best possible care and outcomes for lung cancer patients. A round of applause for Dr. Anand, please. Next, we have Dr. Jennifer Leong. Dr. Jennifer has been a consultant clinical oncologist at Sunway Medical Centre since 2020. In 2019, she was awarded the Excellent Service Award for her outstanding work performance at the National Cancer Institute. She offers advice on systemic therapy for various cancer sites, and her key area of interest lies in the management of lung, hepatobiliary, and gynecological cancers. Beyond clinical work, Dr. Jennifer is a huge advocate on patient advocacy and raising awareness amongst the public, and has appeared in numerous public talks. And she is also raising awareness a lot on campaigns to increase health literacy on lung, pancreatic, and breast cancer, as well as the importance of genetic testing. She currently holds the position of an executive committee member in the City Cancer Challenge in Greater Petaling, which aims to improve accessibility of cancer treatment to the community and strengthening the local healthcare system. So in case any one of you know, that is something that Roche actually passionately advocates for, especially when it comes to the City Cancer Challenge. Round of applause for Dr. Jennifer, please. Last but not least, we have Associate Professor Dr. Karine Malaysian Chan. Professor Karine Chan, an accomplished associate professor and consultant health psychologist at University Kebangsaan Malaysia, has dedicated her career to pioneering research, particularly in areas such as psychosocial oncology, mental health, and tobacco control. Prof. Karine's impactful work goes beyond academia. She collaborates closely with institutional government associations in Malaysia, local NGOs, and her global reach encompasses partnership with intergovernmental organizations like WHO and UNICEF. Simultaneously, she contributes as a council member for LCNM and a National Advisory Council Board member for Cancer Care Malaysia as well. As she continues to contribute to the betterment of healthcare, Prof. Karine's multifaceted expertise serves as an inspiration and a testament to the transformative power of integrating research, policy, and ethical principles in advancing the field of health psychology. Once again, let's give them all a round of a warm welcome. I'm confident everyone is eager to be enlightened to what they need to share for today. I would also like to draw our live stream viewers that we have opened up Slido for you to place in your questions. Please put in hope. If any one of you like to put in your questions, you can also do it. It's also for our Slido viewers as well. I would now like to pass the mic over to Deepti to begin the session for today. Over to you, Deepti.
Hello. Okay. Welcome everyone to the Breath of Fresh Hope, which is an event initiated by Lung Cancer Network Malaysia in association with Roche. And I'm just really honored and privileged to be moderating this session with our esteemed panel here. Also, welcome to all those who are joining us online today, and thank you for making the time on this very essential and crucial topic. Now, as a woman, of course, and a woman from Asia, I am sometimes a little bit horrified by the statistics that sort of impact us. And let me highlight some of those that really speak to me. So cancer, of course, is one of the most, one of the top 3 reasons for mortality in general across all countries, right? And it is a disease that is growing and spreading and affects more and more young people now. But the biggest challenges or the biggest statistic that I want to highlight is that of all the adults, when I say adults, people who are less than 50 years old, when you look at who get impacted by cancer, 2 out of 3 are actually women. So what this means is that cancer affects women at a much younger age than it affects men. Because 2 out of 3 of all those people who have cancer with less than 50 years of age are women. And while cancer is debilitating, and this is the statistics, in Asia, we have other alarming statistics as well, especially for lung cancer. So 60% of the lung cancer burden is in Asia. But even more alarming is that 62% is the mortality rate when it comes to lung cancer. If you go further, lung cancer is actually growing by almost 80%, especially in women, and like I said, young women. And usually there is a myth with lung cancer that it affects smokers, but you'd be surprised to know that only 2% of the women are actually smoking. So 99% or 98% of the women are non-smokers and are getting affected by lung cancer. So it is definitely, overall cancer is a big disease, as we know, but even more alarming is the fact that there are so many myths associated with it, like the one for lung cancer. And it obviously, the other big challenge is how women and in general, how cancer care is accessed by women. Healthcare systems are not designed specifically to integrate or to understand women's needs, and we're going to talk about that with our panel here. They are designed for male and females equally, but if I can say so, they're obviously a bit more male-centric than they are women-centric. cancer care and nurses and a lot of doctors and healthcare professionals in the industry are women, but when it comes to receiving care, the way women are not receiving the right amount of care, sometimes the symptoms are ignored. And I was earlier in another session where we were listening to stories where women's diseases, and when women talk about their symptoms, how they're often dismissed in the system, right, in the healthcare system. And because of which there is late diagnosis, there is late treatment, and decision-making is not done by the woman herself. So to speak a little bit more about these challenges that women face, but more importantly, what are the opportunities that we can then work towards to make this a different story in Malaysia? How can we change the system in Malaysia so that women in Malaysia with lung cancer can have better healthcare? Let's talk about both the challenges but the opportunities as well. I thought it would be great to work with the team of experts here who look at lung cancer on a daily basis and understand from them what are the real on-the-ground challenges, but also understand what are the real and tangible opportunities and solutions that we can address for women in lung cancer. So I'm really thankful for being joined by the three of you. So maybe on that note, let me ask my first question. I mean, I of course spoke about alarming statistics here, but can you all tell me like stories or one story that has sort of in your last few years really, spoken to you personally about the challenges in lung cancer? And whoever would like to start, but maybe Dr. Jennifer, would you, as a woman, like to start the panel and kick it off?
Hi, good afternoon, everyone. Thank you for all those that tune in physically as well as online. So I think on behalf of the panelists, I have to say we are very honored to be here today in raising awareness on lung cancer in women. So we're shining a spotlight on this disease. So what really attracts me to paying more attention or making this my key area of interest, lung cancer being one of it, is that we are seeing more and more younger generation getting lung cancer. As of the moment, my youngest patient is a 27-year-old male, and he's a non-smoker. So he's just finished schooling and just started working for 2 years. And he started to have shortness of breath a little bit here and there. And so because he's young and he's fit and he's a non-smoker, he does not fit into the stereotypical. The first thing that you don't think of is, I may be having a lung cancer. And he did not have cough either. So it's when he started to become more breathless as he walks a little bit more. So he came into the emergency department and had a chest x-ray. And it was found to have actually right pleural effusion, essentially water that's accumulating just outside the lining of the lungs. So then he was worked up and was found to have a stage 4 lung cancer. So I think there's a lot that we can do and we are doing. We are going towards the right direction. And for a start, like having this platform to increase the awareness that when you do have the symptoms, do not brush it off. If it doesn't get better in 4 to 6 weeks, seek a second opinion or seek a specialist's help. Maybe something as simple as imaging will actually save someone's life. And this goes towards not just ourselves, but our loved ones as well.
Thank you so much. Dr. Anand?
Thank you very much, Dipti, and thank you everyone for kindly joining us today. Yeah, I think, for the longest of times, we associate, perhaps rightly, lung cancer as a male smoker's disease. And I think I want to state the obvious, that still in the majority of cases, yes, it is a disease of smokers, in that tobacco smoking is the most common risk factor, the most identifiable risk factor, and most importantly, the most preventable risk factor. But having said that, we are now starting to see increasing numbers of cases of lung cancer in non-smokers or never smokers, of whom women are overrepresented, hence today's discussion. And it's very important that, as society as a whole, as well as the medical profession, that we start to, it's what I refer to as the changing face of lung cancer. The demographics are changing. So it's a disease that does not discriminate. And, we can talk a little bit later perhaps about the causation as to why we're seeing more cases of lung cancer in non-smokers or never smokers. But it's important to understand that the demographics or the clinical profile of the disease is changing. So it's no longer just in men or in smokers. I mean, just to follow on from Jennifer's, the youngest patient I've actually operated on for lung cancer was a 29-year-old girl, Chinese lady, and she had no family history of the disease. She was a non-smoker. She had just got engaged, and she was taking up employment in Singapore. And as part of the employment, she needed to do a chest X-ray. And she was completely asymptomatic, in other words, no symptoms. And lo and behold, on that screening employment chest X-ray, they found a shadow on the lung, and then she went on to be investigated. So unfortunately, someone like her would continue to escape the sort of criteria of whom we target for screening and so forth. But, that's not to say this is very much I wouldn't say it's preventable, but it's very much a curable disease if we can detect it early on. So that's the challenge.
Thank you so much. Do you want to share any stories that have recently inspired you around lung cancer?
Okay, so one of the things that intrigued me about why specifically psychological issues in patients with lung cancer, it's because for the longest part I've been active in tobacco control, and we see a lot of patients, we inherently associate lung cancer with smoking, with the use of tobacco. So a lot of that has been, as part of the efforts to denormalize smoking, we're starting to see a lot of patients with lung cancer who have never been smokers, the never smokers we call them. They actually end up being discriminated against. There's a stigma attached to it. And so you see that in part and parcel that tobacco control efforts have contributed to this in a sense. So there's also a bit of guilt there. And so it has contributed to this stigma of patients feeling that they had to be blamed for the lung cancer that they acquired. And it's somehow also perceived as something that's self-inflicted. So there's a double burden of disease there, not just the fact that they have lung cancer, which is tied to higher mortality, and through no fault of their own, but because of the very strong associations with smoking and tobacco use, they had that sense of guilt. What did I do wrong?
Yeah.
What did I do to end up with lung cancer? You see?
I think, thank you for highlighting that. I didn't realize that, people who are not smoking and get lung cancer, there could be a stigma attached to the fact that you brought this upon yourself, but poor guys have never even smoked in their lives. That's really enlightening. Maybe we can get into the thick of things. So maybe Dr. Jennifer, if you can highlight a little bit about a typical journey of a woman in the lung cancer, space. What does it look like, and what happens, and how do they get diagnosed, and yeah.
So apart from these, screening X-ray, like for employment, most of the women who comes in would be symptomatic. And the usual symptoms that they will have is cough that isn't going away, but cough that goes away and comes back in the a duration of few months, usually 4 to 6 months. And if you tease a little bit longer, it could be up to a year. And then they come in, usually with the persuasion of family members and loved ones. But what really brings them into the hospital immediately usually is they see blood in the phlegm, and that kind of gives them a warning sign. And of course, then a chest pain and some sort, and they think it's a heart problem. And so go into the emergency department, or they see a family practitioner, and they get an X-ray done. That was done at the first place, and you'll find that there is some suspicious lesion in the X-ray. That's when they will be referred to a chest physician most of the time, and then they'll be counseled for a biopsy, a scan. So the biopsy essentially is to take a specimen of the mass for us to confirm that this is a cancer. And then the patient or the woman would then be advised for a scan, because we need to determine the stage of the cancer. If it's a localized stage, and then they will be referred to a cardiothoracic surgeon like Dr. Anand. And if it's an advanced stage or a locally advanced stage where it has involved the nodes and or it has gone to other part, it's quite common for lung cancer when it's advanced. It will spread to the liver or even the bone, and even up to 4 out of 10 patients will have disease up in the brain, and they could be well. So that's why we will do all the screening and then stage the patient. So if it's a patient who had an advanced disease and it's not curative from the start, then the patient will be referred to myself. And when the patient comes in, you can see, not just in lung cancer, I think in all cancer, it's very important as doctors for us to be kind and to give our time to our patient, because they are sitting out there with a lot of doubt and fear, right? And they've just been told that they have cancer. So it takes a lot of diplomacy as well. I think time is something we give for them, and usually it's with family members as well, coming in for support. And so in the first consultation, it will always be about trying to digest what they have without going through a lot of jargon. So it's a lot about what kind of cancer, and then what stage it is. And usually I'll show them the scan findings, where it's important point. And more importantly is to then talk about the treatment as well. So I think the treatment in lung cancer has evolved so dramatically and drastically, and it's been really, really great in this space in the last few years. So it is not about, if I have an advanced lung cancer, there's nothing I can do, but there's a lot of things that can be done, including the introduction of targeted therapy, immunotherapy. So this is where we come in to give hope to the patient. And so then, usually the first consultation is just, getting to know the patient. So there's a lot of follow-up visits where, when they cope with the diagnosis better, and they then start to digest the treatment plan, we can then really go full on about the treatment sequencing.
Thank you so much. And I think you really highlighted the fact that diagnosis is, seems to be the first big challenge, and usually women are known to prioritize everything else in their life, right? And a small cough here and there is not the one that deters them from doing their familial duties and their professional duties as well. So talking a little bit about diagnosis and treatment, Dr. Anand, in your viewpoint, are there big challenges that you would like to highlight? But maybe also, because this is a breath of fresh hope, what's the hope?
Yeah, thank you very much. I mean, just to follow on from what Dr. Jennifer said, I think I'm sure most people are familiar that in the last 5 years, I think there's been tremendous advances, right, to give everyone hope, and this is realistic hope, tremendous advances in the diagnostic and treatment landscape for lung cancer here in Malaysia and globally. And we are talking about precision diagnostics, and we are talking about personalized therapies. And these are not just, fancy words. We talk about being able to study the biology of the tumor in detail, next generation sequencing, genomic molecular profiling, and novel treatments, as Jennifer mentioned, like antibody drug conjugates, immunotherapies, oral targeted therapies. And these treatments, the diagnosis and treatments, in my opinion, it's revolutionized lung cancer care in the last 4 or 5 years. And it's translated into significantly better outcomes for our patients in terms of what we call as progression-free or disease-free survival, meaning patients get to live longer without their cancer or without a relapse, as well as overall survival. But the challenge is, despite all these tremendous advances, the fact remains a majority of patients are still being diagnosed late in stages 3 and 4. The most contemporary data we have for Malaysia is quite old now. It's the National Cancer Registry Report, 2012 to 2016. So that's quite a while ago, but almost 95% of cases here are being detected in stage 3 and stage 4. So for me, the challenge is we need to pick up the disease earlier, because I'm sure everyone appreciates if we can detect lung cancer earlier, it is potentially curable. It's more amenable to treatments with a curative intent, better outcomes, and it's also cheaper for the patient and for society at large. Now, how do we actually pick up the disease earlier? When we talk about diagnosis, for me, it's 2 things. One is we need to create greater awareness, and this is where we need the media to help us as well, to educate people. 1, red flag symptoms. We've mentioned if you have a persistent cough, more than 2 weeks duration, you're having recurrent chest infections, these are symptoms not to be ignored. You have to consult a doctor, get it checked out. But the fact is the majority of people with early stage lung cancer will have little or no symptoms, and that's the difficulty, or that's the challenge. And this is where I feel strongly we have to push the agenda for screening, which is to pick up the disease before one develops symptoms. But obviously for screening to be effective, cost-effective, for it to be impactful, it has to be targeted screening, which means we need to define at-risk or high-risk populations. which very briefly would be, looking at the context in Malaysia, it would be anyone over the age of 45 who is a current or former smoker with at least a 20-pack-year history. In other words, they've been smoking a pack a day, cigarettes, for at least 20 years, or two packs a day for 10 years. But I would also add to that, we need to start to address the high-risk non-smoker, which is basically, unfortunately, women are overrepresented in that cohort. And I think family history is emerging as a major risk factor. So we have to start to widen the net to capture, I suspect many cases of lung cancer in the non-smoker is actually inadvertent chronic cumulative exposure to secondhand smoke, tobacco smoke. So it's greater awareness and then collectively pushing the agenda for appropriate targeted screening. So what we are trying to achieve is stage shift. In other words, pick up more people with lung cancer at an earlier stage when the disease is amenable to cure. That is usually surgery in combination with other treatments, as Jennifer mentioned, such as chemotherapy or immunotherapy or oral targeted therapies. So it's that multimodal approach. Yeah.
Thank you so much. And you mentioned that even with all the hope that we have and advances, I remember there was a time where there was nothing available for lung cancer. Maybe not that long ago, right? Like maybe 10 years ago, there was like literally no solutions, right?
It was 10 years ago. Someone who has a stage 4 lung cancer is just given 6 months of survival and chemotherapy at best. Yeah, but they were then referred very early on to palliative care. We've gone really a long way in the last decade. And we have patients with stage 4 lung cancer who's on oral targeted therapy for 5 years and still going very strong. So it says that if we get the disease and we get the molecular testing and we find out what kind of mutation drives the cancer, so we call it the precision medicine, we can really change the treatment pathway of that patient these days.
Thank you. And so like I was saying, there's hope, but still, the diagnosis is delayed. And then, obviously in women, this is even more likely to happen. So Dr. Kareen, coming to you, what do you think are the social stigmas? And you mentioned some of that in your opening, but what holds women back from getting screened and diagnosed early, but in general, prioritizing health earlier?
All right, thank you for the question, Deputy. So the key thing here is you mentioned the advances in treatment, but the problem is that the majority of people in the public, they aren't aware of that. To them, one of the main stigmas attached to lung cancer is that we're seeing a great deal still of therapeutic nihilism. That is essentially the belief that there is nothing that's going to cure my cancer. If I end up with lung cancer, that's it for me. And there's a great deal, of course, there is higher mortality attached to lung cancer compared to other cancer types. So that is part and parcel of what drives the fear. So even when they have symptoms, they are still reluctant to come forward. And it's very easy, especially for women, who can get so very caught up in caregiving, caring for, in our society, where we're very, very much collectivistic. We're engrossed in caring for children, for husbands, for family members, elder care. All of this was highlighted in the Lancet commission that was launched this morning as well. The fact that women are very much the people who are involved in unpaid caregiving. And so they tend to prioritize family, even work for women who have careers, and over at the expense of their own health. So they never find it's a matter of priority, but because they are taught, society teaches us that in this setting, to be seen as a good mother, to be seen as a good employee, to be seen as a good wife, you need to sacrifice and put the needs of everybody else first. But where do they come in? So it's very easy to dismiss their own symptoms. All right? So that is part and parcel of what contributes to the issue here that we're seeing. So there's a great deal of fear coming in to get help, to seek treatment.
Yeah. And maybe, therefore, to both of you, right, as doctors, when women come into your clinics, and especially these young women that we are talking about, what and how different is the approach that you think has to be applied from men versus women, right? And what needs to be done as a doctor to convince them to be on treatment and to sustain that treatment? Like, if you have examples or real stories, that would be also awesome.
So I think, Karen really eloquently put, the fact that women are often put priorities among our work, our children, our family first, and health sometimes can take a back seat. So a lot of time when the women are diagnosed with lung cancer, and I have many women that are diagnosed with advanced lung cancer in recent months, I think it comes as a shock to them that they have lung cancer. Because lung cancer is often stigmatized with tobacco smoking. So they don't smoke, they lead a relatively healthy life, they have a relatively healthy diet, they exercise, and most of them are working, having young families. So all of a sudden they get diagnosed with advanced lung cancer. So I think we have to let them have some time to digest this diagnosis. And more importantly, now is the time, how I put them through the treatment is that now is the time to focus on your health. And a lot of time, women are motivated to partake in the treatment, not just for themselves, they do it for their family. And it's the truth. It goes the same with genetic testing for breast and ovarian cancer. So they will do it because it may have an impact on my daughter, that if I have a genetic mutation, my daughter may have it, and I don't want her to have an advanced cancer when it's detected. So there are a lot of that, effect that we worked on. But a lot of women then do it because they want to get better for the family. But I think there's also a guilt because women are so used to being the caretaker as well. So when they get this disease and they need help from the family, there's often an unwritten guilt that, I'm going to burden them. Because cancer treatment is expensive. So it's not just financial burden, it's also physical burden, having to bring me for treatment. So we try to get the family involved as well. It's a supportive care. So, and to say that, it's a teamwork, and that you're not burdening anyone, and it's time to put your health as a priority and get you back on track to getting better and normalize their life, because we don't want cancer patients to be stigmatized, that you're walking around with the word cancer on your forehead. We want them to normalize their life, go for holidays, spend the time they have with their family in a meaningful way. Hence, the treatment also need not be detrimental. We don't want to have treatment that puts them in the bed most of the time, and they can't eat, they can't walk. So it's all a lot of holistic care these days when it comes to cancer care.
And Dr. Anand, do you want to highlight that a whole compound is involved, I think, in cancer treatment, and especially when it comes to women, right? Like, as a doctor, how do you address the family, right? Like, and what needs to be done differently when a man is sitting on the chair of the patient versus a woman is sitting in the chair of a patient? Is there a different approach that you use?
Not entirely. Okay. I think a diagnosis of lung cancer is devastating for anyone, especially if especially when it involves younger people. And I guess it's all the more, shocking if it's someone who doesn't smoke, because we assume if you don't smoke, you won't get lung cancer. That's no longer the case. So I think it's very important that when we, in that consultation, there's a lot of information that we need to distill to the patient. And that has to be done with empathy. You need to communicate very clearly, but with empathy. And they will have a lot of unanswered questions, and you have to give that person and their family and caregivers time. So it is very rare for a patient to come on their own. They will usually come with some family members, a spouse, children, etc., their parents if it's a younger patient. And we try to engage the whole family. It really is a journey in terms of, trying to take them through what are the next steps, diagnosis, staging. They will have inevitable questions about prognosis and, whether... So the treatment and the prognosis, as we all know, is very much stage dependent, right? So it's, a lot of that consultation is trying to establish the diagnosis and the stage as accurately as possible, because it's going to dictate the next step of clinical management for that person, for that patient. And perhaps we sometimes need to spend more time, to also address the other non-medical aspects of it.
And maybe that brings me, you spoke about the empathy that's needed in such a situation, and you also spoke about, giving them time to, digest this. Dr. Karen, what kind of, you spoke about the social stigma, right? What kind of social support and, how important is the psychological well-being of the patient in this journey, right? And what needs to be done from a societal perspective so that, we can maintain this hope for the patients of lung cancer?
Okay, that's a big ask from a societal approach. Okay, let's break it down. So I think right off the bat, for a lot of patients and their caregivers, at a lot of time they don't know where to turn to for help. And there's also a great deal of stigma where if they're recommended to see a counselor or psychologist or psychiatrist, they go like, no, I'm not crazy. I know I don't have mental issues, so why do I need to go there? So in our setting, we tend to see very few patients actually accept that kind of referral to formal psychological support services. So I think the important thing to remember here is that patients can get support from other areas. You can get from support groups, from NGOs, from their family members, if it works for them. At the same time, there's also a huge unfair burden sometimes on caregivers and friends. They're not necessarily trained to deal with talking about issues like death and dying with a person who's been diagnosed with lung cancer. You can be your best friend. It doesn't mean that you know how to address these issues in a sensitive way, of a way that works for the patient. So you can actually end up saying things that are insensitive, off the mark, and it could actually break down the relationship. So I think the important thing here is that patients need to know that you don't, there are modes of formal support you can seek, but you can also get help from informal support like NGOs and patient support groups. So,
Yeah, thanks. Coming back a little bit to women, and you know, we have been saying that there's a stigma attached to it. There are some myths like smoking is the only cause. What are the common myths that you have heard from people, you know, when it comes to common myths, common misconceptions, especially with lung cancer in women?
I would say the biggest barrier, the biggest misconception would be the tobacco smoking. A lot of women still do not have the family history to support them, as what Dr. Hanan has mentioned. But we know now from many studies that family history of a patient with of an individual with family history of lung cancer is a very strong predictor of someone that needs to be screened. And the current guideline recommends 45 years and above. Yeah, but of course in Malaysia, we're still working towards, you know, getting the screening guideline. And hopefully there'll be something that we can put on for non-smokers. Because these are the group that does not get the, you know, potentially the yearly low-dose CT and sort. Apart from that, I think generally, no, there's not much misconception. But what I often get is it something that I've eaten? Yeah, you know, I've taken some supplement in the last couple of weeks or months. Because diet is a very important topic. You know, it's probably precede more time talking about diet than treatment. Because patient wants to know the things that they can empower themselves with, right? The things that they can do to make themselves better. So it'll be about, is this the diet that, you know, caused it? So we know there are no exact science or linkage between diet and development of lung cancer. But what has been shown, the factors that can lead to lung cancer, besides epigenetic mutation, would be family history, and then also exposure to radon, exposure to cooking oil without ventilation. So a very big study in Taiwan, known as the Talent Study, actually looked into 12,000 patients, and they have a lung detection rate of 3%. It may seem low, but it's getting there. You know, they actually managed to pick up early stage lung cancer. And one of the criteria they looked at was patients who have family, individuals who have family history of lung cancer, either a parent, a sibling, yeah, or a child. And also they look into cooking exposure. Yeah, those direct contact with fumes, and then with or without ventilation. And very importantly is the second-hand smokers. Yeah, they actually are in the high-risk group. So hopefully in the next few years, these are the group that we want to look into how we can better our screening, you know, process in getting them to be screened regularly.
If I can just add to what Jennifer was saying in terms of that study, the Talent Study, it's a study from Taiwan, which has demonstrated that screening for lung cancer in high-risk non-smokers is truly life-saving. And the study demonstrated quite clearly that that risk, it's an incremental risk, the more first-degree relatives you have. So absolutely, this is one of the messages we hope to get out, that it's no longer just a male smoker's disease. And in non-smokers or never smokers, family history is something we need to pay attention to. So if someone has a family history of lung cancer, then unfortunately you have a elevated risk and should explore screening. So that's very important as well.
So just to clarify, passive smoking or a male family member smoking in your family could be a high risk for the woman in the family, right? I'm just confirming and validating this with you guys, yeah?
I think absolutely. If we use a broad term of air pollution, the WHO, the World Health Organization, now recognizes air pollution as a carcinogen, as a risk factor for lung cancer in non-smokers or never smokers. And within that umbrella term of air pollution, I would include exposure to secondhand smoke. We'll say by the spouse, whether at the workplace or at home. And it's that chronic cumulative exposure over a long period of time is thought to trigger some inflammatory response in genetically susceptible people. So someone who may have that common mutation in Asia, the EGFR mutation. So you need something that comes along as a trigger. So I think secondhand smoke, air pollution, we don't know the long-term effects of the annual transboundary haze, but these things I think, will all increase the risk long-term, yeah.
Great. Maybe then my question really is like, what can be done to sort of help women who are subjected to passive smoking in general and therefore lung cancer? What can be done in terms of equitable access to treatment? And do you feel like when it comes to decision making, when these women are talking to all three of you, how empowered are they in decision making when it comes to decisions for themselves? And then what can be done to make it more equitable in terms of access? And maybe Dr. Anand, you can start with telling us what your thoughts are on that one. But yeah, what can be done?
Decision making, as I said, I think whether you're a man or a woman, young or old, it's a devastating diagnosis. Important decisions have to be made quite quickly. And as what Karen alluded to, you need a good social support structure, hopefully family, caregivers, sometimes professional help. You need to do some amount of research. Lung Cancer Network Malaysia, we have come out with material, credible information to help patients, caregivers navigate that journey. It's very complex, and we try to guide patients to make informed decisions along the way. But in terms of equitable access, I think it very much, obviously everybody, every citizen, every resident should really be able to access quality healthcare as and when one needs it, And we, as a developed country, we should aspire to providing very sort of evidence-based, comprehensive, contemporary, holistic care, cancer care, not just for lung cancer, but cancer care, to anyone who needs it. Ideally, it should be affordable, it should be provided in a timely manner, and it should be delivered, with compassion, with empathy. But in real terms, of course, we have issues of cost constraints, and we also have provision of services. So, for example, somebody here in Kuala Lumpur, in a capital city, in an urban setting, may be able to access certain services or facilities or see certain relevant specialists much more quickly than, say, for example, someone who may be in a smaller town, say in the East Coast or even in East Malaysia. So, I can share with you, for example, 3/4 of the PET scan machines in Malaysia are located in Klang Valley. So a PET scan is a scan that is done to stage the disease, to see the extent of spread for any cancer, including lung cancer. So there is this geographical discordance, maldistribution of facilities and sometimes services. In the public sector, the system is obviously overwhelmed with caseload. In the private sector, the constraint is to do with cost in terms of the payment. But I'm hoping that we can leverage on that public-private partnership that started during the peak of the COVID pandemic and have a better integration, harmonization of services, maybe a hub-and-spoke model, have centers of excellence where patients can be quickly referred on, worked up. Because when we talk about cancer, and certainly lung cancer, time is of the essence. Progression from early to late stage is a real and serious concern as well. And just very briefly, finally, in terms of the cost, We know in Malaysia, medical inflation is about 10-12% per annum. And, you know, the majority of the population, I think less than half have insurance, and most are grossly underinsured. So if you're looking at out-of-pocket payments, the costs, you know, cancer care is complex, cancer care is very costly, and very quickly financial catastrophe can ensue. So it's challenging. I mean, it's been talked about for a long time, health financing, universal health coverage. Hopefully that comes up in the health white paper, yeah.
Maybe Dr. Kareen, since you are also in the policy space and have been working in that space, can you tell us a little bit about, you know, and also based on your research, I think, what collaborative efforts or how can we have better collaboration, you know, between government bodies, you know, scientific experts like themselves, pharmaceutical industry, private sector, you know, how can we all come together to change this, right? Get earlier diagnosis so that women can live longer. And it doesn't matter where you live, you should have equal chances, right? Yeah. So, yeah, and like Dr. Anand mentioned, it's all concentrated in the Klang Valley right now. So yeah, what do you suggest? How do we collaborate better and more effectively to make this shift happen?
Dapti, I think that's an important point you raised. I think what we actually need and we're looking at right now is multi-sectoral collaboration. That means there needs to be partnership, not just academia doing research, but it has to be joined together with other stakeholders like the Ministry of Health, even the Ministry of Education, with pharma, with industry, with NGOs, and also patients themselves. And at the end of the day, we can have all of these guidelines, all of these policies, but if we don't have, this needs to be guided by research priorities that needs to be set out by people in these various areas, in these different industries and in different stakeholders, so that we know what are the key things to focus on. For example, like we now know that there are more and more patients who are never smokers. So, but we don't really have that much data. There isn't much evidence yet. So is there some sort of, do we need to set up a registry? We need to collect the data so that we know what kind of risk factors to look out for example. And then we know that there are areas of unmet need and support. What are we doing about it? So for example, we know that there's never going to be enough psychologists, psychiatrists, mental health people looking at patients with in lung cancer for the next 5-10 years. So it's very important to work with other people in this area, for example, with the NGOs, to train others, like to empower other cancer survivors to help patients, those who are actively undergoing treatment, for example, because we can't profess to understand what the patients are going through. And so that's why I think it's very important to empower those who are actually survivors to help out one of their own.
Yeah. Leveraging survivors to make the shift happen and amplify the needs.
Yes.
Right. Thank you. We also started to get lots of questions on Slido, so maybe I'm going to also address some of those. And one of the questions is what are the common risk factors? But is there a race in Malaysia that's more prone to lung cancer than the others? But if that's not the case, maybe you can also talk a little bit. You've already spoken a little bit about the risk factors, but are there any other risk factors that you would like to highlight? So maybe Dr. Jennifer, you want to take that one?
Yeah, just to recapitulate the risk factors, of course, tobacco smoking plays the most important, highest risk factor there, not just for lung cancer, for many other cancers as well, including head and neck cancers. So apart from that, in the non-smokers, family history of first-degree relative, so that's your parents, children, siblings, and then exposure, air pollution that Dr. Anand has mentioned. So all sorts, of course, maybe not in this part of the world, but those who live in the basement, sometimes they have to have a radon meter to check how much radon exposure they have over a long term. And air pollution includes cooking. So I think those are the common risk factors that has been shown to increase the risk of lung cancer.
Can I just add, if the question was race as in ethnicity, yes. So we do actually have from our own Malaysian data, if you look at the National Cancer Registry reports, the last two, if you're ethnically Chinese, then your risk of lung cancer, I can't talk about other malignancies, is twofold, twice that of a non-Chinese, adjusting for age and adjusting for gender. So if we compared a Chinese lady with an Indian or Malay lady, and similarly a Chinese gentleman with a Malay or Indian gentleman, adjusting for age, etc. So whether there's genetic predisposition, that is a factor. So we look at all of this in clinical risk profiling as well: the ethnicity, the age, the smoking history, the family history, etc. In addition to looking at scans and images. Yeah.
The only other cancer that pops out with ethnicity in mind is nasopharyngeal cancer, also extremely high prevalence among the Chinese compared to the Malay and the Indians.
So Chinese women not smoking, but if husbands are smoking, you are at a high risk, right? And then one should be very aware, and like Dr. Kareen mentioned, prioritize your health, and if you have this persistent cough, take quick actions. I think there is one which is specifically for you, Dr. Anand, and it talks about vaping. Vaping becoming such a big trend. What's the connection with lung cancer? And what are your thoughts on that?
I mean, I'm not a tobacco expert. Vaping, the short answer is vaping's not been around long enough for us to conclude that it, on its own, that it's a risk factor for future lung cancer. What we do know is that if we look at our own National Health Morbidity Survey, the incidence of vaping and e-cigarettes is going up amongst young people. And a lot of these vapes are not regulated up until recently. There's a lot of nicotine. Nicotine is highly addictive. And there's quite a lot of data out there that people who vape are many times more likely to end up with tobacco smoking. So, if you extrapolate from there, then I guess the long-term risk is there. We know about acute lung injury, EVALI, e-cigarettes and vaping-associated lung injury. And I guess any condition that causes inflammation in the lung tissue, often there's healing, and we don't know the long-term effects, whether a cancer could develop within that scarred tissue months or years or decades later. But right now, we can't say there's no strong evidence to say vaping will cause lung cancer, but we have every reason to believe that it's not good for you. Yeah.
Of course. Vaping is also a big trend in the younger generation. So Dr. Kareen, my question is there any different kind of approach that's needed in terms of psychological support when it comes to the younger women and, especially with lung cancer? Do you, what are your thoughts on that? Yeah.
We see a lot of women with cancer, not just in lung CA. We see a lot of them coming in with concerns, not just about death and dying towards the end of life, but they also worry persistently about their family members. They worry about children, they worry about elderly parents or in-laws they are no longer able to care for, their husbands, and you see that kind of fear and that kind of worry rather than what's going to happen to them, what's going to happen to my children. Yeah. And also we know that women, research already indicates that women are more likely to suffer financial catastrophe compared to men. And this, in effect, we also have a lot of patients who come in saying that, their husbands, they are more likely to be left by their husbands in the event that they acquire lung cancer, breast cancer, and that's sad. So that's one of the key things that we need to look into.
It needs a societal change, and the value of women overall has to rise. Any questions on the floor? And I just want to make sure that I'm addressing if there were any big burning questions that the team here had. Yes, sure.
What we know is the smoking prevalence among adult males, I'm sure you're familiar, is quite high in Malaysia. It's about 45%. So Malaysian men 18 and above, very high. And I think in Malaysian women, it's very low, it's less than 2%. And there was a recent publication that maybe, now it's obviously some years ago, that up to 90% of men who are diagnosed with lung cancer have a tobacco smoking history. With women, it's estimated that more than 60% have never smoked. I personally reckon that's even higher, but we don't have, or I'm not aware of, clear statistics or data. I can tell you in countries like Singapore and Hong Kong, more than half of all the cases of lung cancer are in non-smokers and never smokers. But they also have a slightly more homogeneous population, higher ethnic Chinese population. We are a more mixed population.
So essentially, say, 25% of lung cancers are in non-smokers, whereas the majority are still contributed by those who smoke. And in that 25%, when it's women, up to 60% are non-smokers. Yeah, so it's how we looked at it. I foresee actually the figure is higher in Malaysia.
I think so too.
Yeah, compared to the Western population.
So that is kind of our anecdotal experience based when we talk to colleagues and based on the patients we see on a daily basis. Of course, there can be some biases depending on who accesses which part of the healthcare system. Yeah.
And so, yeah, go ahead.
You mentioned the primary, Jitsin from MIMS Doctor. What is the primary screening method that you catch someone with lung cancer? Is it an X-ray? Is it an ultrasound?
Well, I mean, the gold standard is a low-dose CT scan. So we have a lot of strong data, randomized clinical trials that tell us clearly that if you target the high risk, up until now it's been people with a tobacco smoking history, current or former smokers of a certain age and certain duration, globally across the world, low-dose CT scan has been shown to be truly life-saving. So what I mean by that, a reduction in the lung cancer-specific mortality. And the low-dose CT scan is widely available here in Malaysia in private and public hospitals, as you know. It is something that can be done very quickly. You don't need, it is a uncontrasted, a non-enhanced, uncontrasted scan. So you don't need a prior blood test. No one puts a needle in your hand. You don't need to fast. You can walk in and do the scan because we're interested in looking at the lung tissue. The resolution is a very high-quality image. Having said that, there are still cost issues and accessibility. There is growing interest globally to re-explore the use of the humble chest X-ray, chest radiograph as a baseline, maybe even as a triage tool. Historically, it's been shown to be not good enough for the purposes of screening. But recently, we are trying to explore the use of AI, artificial intelligence, which increases the diagnostic. It's been demonstrated to increase the diagnostic sensitivity and accuracy. So I see it as a way to not to replace the LDCT, which is the gold standard, but to complement and maybe as a triage funnel and identify the right patients who can then go on. So, you know, a chest X-ray can be deployed at clinic kesehatans and at GP clinics in the community, much cheaper, easily accessible, and you don't even need a radiologist on site because the project that LCNM spearheaded a couple of years ago used software, AI software from India, QAI, which is being widely used in the NHS in the UK and in the US. And it's excellent. It gets uploaded to a cloud-based, and it generates a report within a minute. And that report is commensurate with a trained radiologist report, looking at a lot of pathologies, including lung cancer. So what we're looking for is, we term it an IPN, an indeterminate pulmonary nodule. Because for the purpose of screening, we hope to pick up lung cancer early, and it'll manifest as an opacity or a little patch on the X-ray, and then it may not be lung cancer, but the next step in that algorithm is for that person to be counseled and go on to get the definitive low-dose CT scan. And then they may or may not need a biopsy, or they may need a follow-up scan and so forth. Yeah.
So I'd like to jump in there. So that's why we already know the standard of care, the methods of screening is the same, whether it's for men or women. So the key thing here is for them to recognize for patients, non-patients, for people in the public, the general community, women, men, to realize that you have symptoms, you need to get it checked out. You've been coughing for 3 days, you've been coughing for 3 weeks or more, you have all, because the problem is that the recognition of symptoms, there are not very many symptoms, early symptoms of lung CA to go by. So you have to be on alert, and you have to have that vis perception. You can't think you're invulnerable and that you're never going to get lung cancer because it's a smoker's disease and it's not going to be you. So at the end of the day, we have to make this population aware that, you know, you don't have to be a smoker to be at high risk of lung CA. That's why education and literacy is so important here.
So one thing sorry, go ahead.
Yeah, I'd like to emphasize on that. I think that's why we're in this dialogue today. All of us have a part to play in raising awareness. So if you have a friend or a loved one who have symptoms, please urge them to seek, medical help, but also to recognize when you're in the high-risk group. that you can actually go and see, a specialist and ask if you, fit into criteria of even a basic chest X-ray or a low-dose CT.
Yeah. No, I do know, I'm also from the pharmaceutical industry, so have a little bit of lesser understanding, but a little bit of understanding. So diagnosis is one big challenge, right? Do you feel like the diagnosis of lung cancer in women is slightly different from the diagnosis of male patients? We do know that lung cancer has a lot of mutations involved, right? Do you see any difference in the kind of pattern of disease between men and women?
I suppose that question is directed at me. So we find that women who doesn't smoke, especially Asian, have actually better outcome when it comes to the treatment of lung cancer. They survive longer because in the past 5 years or past decade, we have found the different kind of mutations in Asian non-smoker women. So it would be EGFR, ALK mutation. So these are very foreign name, but what happens is by the recognition or by the discovery of these oncogenic mutation, so what is done is that we do a tumor biopsy, and from there we run the molecular testing, or what we know as next generation sequencing. We are able to identify the mutation that actually drive the cancer to grow, to proliferate further. So you have to put a brake onto this mutation. So it's like I tell my patient in very simplistic term, is that you have to find the door that actually allows the cancer to go and play. So we all don't have the key to our neighbor's door, right? I hope not. So what happens is you find the right key and you can lock up that door. So it's the kind of precision medicine. So if you find an EGFR mutation, then it will be an anti-EGFR drugs. And we find that a lot in Malaysian, not just Malaysian, Asian women. So they have very high oncogenic mutation, even ALK mutation, and so on and so forth. So the first thing that happens when a patient gets diagnosed with lung cancer is that they automatically should be offered a NGS testing. So you can have the imprint or your tumor signature from the get-go, and that's where your doctor can then talk to you about the correct, or the sort of like the precise treatment tailored for yourself. And that is something different from what we see in the past or what we see in the smokers. So essentially, most smokers do not have oncogenic or driver mutation, but they are likely to be more responsive to immunotherapy.
Sorry, I just want to add a bit more to the biology of lung cancer in women. So we have seen across the world in the last 20 years, Jen, how non-small cell lung cancer is the major type of lung cancer. As you know, maybe 80% of lung cancer is non-small cell. And it used to be something called squamous cell carcinoma. But we have watched across the world from the time I was in medical school to now, it has evolved. And now we see adenocarcinoma as the predominant histological cell type. And certainly more so in women and more so in non-smokers. And sometimes the challenge why women get diagnosed later, one, as we've all said, you're not thinking about it. Hey, I don't smoke, I'm a woman, I'm not going to get lung cancer. And they present later. Also, adenocarcinomas sometimes tend to be peripheral. That means in the outer parts of the lung, less likely to present with those symptoms of cough or coughing up blood. And it can be also easily missed on the X-ray as well. But that's a global change, and various theories about it, including the change in smoking patterns from your high tar to low tar filtered cigarettes, and how it's changed across the globe, not just in Malaysia, from squamous to adenocarcinoma. So, but it's still a deadly cancer as well.
So just based on what you both said, are you saying that women in Asia are more prone to mutation-driven lung cancer?
They tend to have a higher mutational kind of burden in the microenvironment of the tumor, which makes them a target for us to consider molecular target, like targeted therapy, rather than systemic chemotherapy. So that's also the message we're saying. Someone who has an advanced lung cancer may not necessarily require systemic chemotherapy, because we know that's also a stigma. Of course, chemotherapy is still a backbone for many of the patients with lung cancer, especially in the early stage. But in the later stage, there is actually other treatment that can be offered, as long as we get the molecular testing and we get the information from that tumor testing.
Right. And so is it therefore that since you have mutation and therefore targeted therapies, that actually if women are diagnosed earlier, they can have better outcomes? Is that how you see the correlation? Or is there something else?
I think the biology of the tumor is very important, but the stage at which they present is also very important, right? So at the end of the day, still, if lung cancer, like all cancers, there are 4 stages to the disease, and stage 1 and stage 2, if a patient is fit enough, the treatment of choice is still surgery, removing that part of the lung. Usually it's called a lobectomy, and clearing out the lymph nodes. This offers the patient the best chance of a cure and long-term survival. But we have now learnt over the years that surgery on its own is inadequate because of a high risk of relapse or recurrence, and it should be part of multimodal treatment. That means in combination sometimes, as what Jennifer said, with chemotherapy or immunotherapy or oral targeted therapies. Just a bit of context, the EGFR mutation, Jennifer's probably more qualified than me to say this, but to the best of my knowledge, the prevalence, the incidence is much higher in Asia, and of course more so in women and non-smokers. It can range as high as 30 to 50% here. And we can contrast that with Western populations, like in the UK and the US, where it's hovering around 10 to 15%. So the biology of the lung cancer is also different. What we are seeing in Asia, East Asia, and Malaysia, a little bit different from Caucasian Western populations. And that opens the door for, as you mentioned, it's amenable to treatments, oral targeted therapies. Yeah.
I think it's also important to highlight that because of how fantastic the treatment of targeted therapy has worked in the stage 4 landscape, then the clinical trials start to evolve, and now they look into the adjuvant therapy, which means patients who have undergone surgery still have a relapse rate in 5 years of about 30%. So meaning if your patient even get diagnosed at stage 1 or 2, they can even have a relapse rate of up to 30%. So what can we do better? So that's where we start to look into trials to introduce, if they have mutation, do we wait till they go into stage 4 to offer them? And the answer is no. So as of today, we actually have 2 mutations where we can offer the patient targeted therapy in the early stage setting after surgery. So it's important to get the molecular testing there upfront, not wait till they're in advanced stage. So the 2 mutations that we can currently offer adjuvant treatment would be in the EGFR mutation setting, as well as a mutation called ALK mutation. So these are fantastic development in the clinical trial, where science has evolved so much, and we're looking into not just sustaining life in advanced setting, but how can we improve control rate in the early setting, the group of patients that we do not want to see relapse, and obviously we want to prolong a survival in this group of patients.
Are there any more questions on this group? I do have one question on the Slido, but let me see if there are more questions here. I mean, of course, we've gone deep into the science now, the mutations and, especially in women being higher. And therefore, one of the questions that I got there was that, you've mentioned quite a bit about targeted therapies, and also you've mentioned a little bit about precision therapy. Are there side effects with such therapies, especially in women? Or what's the quality of life like?
First up, most of the targeted therapy are oral treatment, which again goes to the backbone of why we are treating the patient. I think we got to remember that we don't want the trade-off to be poor quality of life, in the expense of better survival. So most of the oral targeted therapy has side effects that are tolerable and manageable. So I think as an oncologist, it's important to spend time to tell the patient so they know what to expect. And some of the side effects include diarrhea that can be managed with anti-diarrhea, with proper dietary modification, as well as skin rash. So generally, most of the patients do not present with risk of fever because of low white cell. So the risk of admission into hospital, something we looked at. So what we call this is indirect treatment cost, because cancer treatment isn't just looking at the cost of the treatment. You've got to look at the other expenses, such as hospitalization costs. They can cause loss of productivity when you have to take MC from work. So all these are actually minimized when you are on the oral targeted therapy. But of course, not everyone is suitable for it. Like Dr. Anand said, about 30 to 40% may harbor the mutation. So a lot of patients with stage 1 to 3 lung cancer who has been operated still require, most of them, up to 90% will require systemic chemotherapy. But whether then you do maintain them with targeted therapy, so it's something you can explore with the doctors.
If I can just add, Dipti, I think one of the toxicities is financial toxicity. So this, I'm being frank, I probably won't get invited back, but a lot of the novel treatments, they are game-changing, impact patients' outcomes, but they're very expensive. And as clinicians, what we try to do is help patients on an individual basis. So sometimes recruit them as part of a clinical trial if they're an appropriate candidate. Of course, they may not always get the medication, they may get a placebo. We work closely with the pharmaceutical industry. Most of the companies have patient assistance programs, and those who qualify, we try to help offset the costs. Because it's very, very demoralizing and difficult for us as clinicians. These medications are highly efficacious, meaning they're very effective, and they make a huge difference. And then what the limitation is the actual costs. So this is obviously something that is a different discussion, but trying to make it more affordable.
If I was on that side, I'm sure this question would have been posed to me as a pharma company, right? Like the pricing of drugs, etc. But I would say that, there are two elements to all this, right? So one is, of course, as pharma companies, we do our best in pricing as effectively as possible based on the paying capacity, etc. But what we also try and do is the Roche assist programs, or in case of Roche, but all, like you said, all companies offer patient assistance programs where we try to, subsidize the cost for patients for these kind of targeted therapies. But the second part is that you do need investments from the government at the end of the day, and policies that really invest in the healthcare system, which enable women or men to be diagnosed early, screened early, diagnosed early, and then access of equitable, good healthcare. And it cannot be a burden on any one side, and I think that's where the private and the public partnerships are so important in bridging this financial toxicity gap for patients, right? But one thing is for sure, that it seems like there is hope for women and men with lung cancer. 10 years ago, there was 6 months given, and today I think what we are saying is that firstly, we understand better about this disease and the causes, and you guys have mentioned so much about, the main causes, of course, is tobacco in men, but all those non-smokers, passive smoking can be one of the causes, and of course, family history is one of the other genetic reasons. What you have also mentioned is the kind of care, empathy, compassion that's needed when women or men also get diagnosed, right? It's quite shocking if you're a non-smoker, because socially there's so much stigma around this that you have brought it upon yourself by smoking, right? So you almost deserve this, right? Because you've been smoking. But there are so many of the people who are not smoking, and the growth rate in that segment is more than 80%, right? So we need to, as a society, be aware that there are more causes than just tobacco smoking, and we cannot stigmatize, especially non-smoking women, about this. But the biggest hope is in the diagnosis and treatment, because like Dr. Anand, Dr. Jennifer mentioned, there is so much progress that has happened over the last few years when it comes to low-dose CT scan, NGS, or comprehensive genomic profiling, which can identify the specific targeted, targeted gene on your tumor that can help you. So I think that's really great. And then there is, of course, more treatment options available, as you have mentioned, from targeted therapies, better systemic chemotherapies, to also now immunotherapies. And of course, in terms of diagnosis, there's also technology, like our AI-based technology that LCNM is sort of supporting to make sure that patients can get diagnosed earlier. So there is a lot of hope. The point is, how can we motivate our women to get screened, diagnosed, and prioritize their health? And then when they do get diagnosed with cancer, lung cancer, there's no hope lost. There is so much available in terms of treatment that can change their quality of life, and that can help them to sustain whatever life that they want to lead. On that note, I want to end with one question. Like, what can people here do to make a shift, especially from a community sense, right? Like, what can we all do, each one do? Like, we've heard a lot now, but what can each one of us do a little bit to make this shift for lung cancer? Whoever is ready to start.
When I asked my friend, do you know lung cancer can affect non-smokers? And my girlfriend said they don't know. And they don't know it's the 4th most common cancer in Malaysian women. So when we go home today, I would like you to remember, because things that we are not aware, we won't be, thinking about it. Someone who has a cough, our mom, our siblings, our sisters, our best friend. So the take-home message for us today would be lung cancer can affect women, and it's a real threat in terms of the cancer mortality. It has one of the highest mortality rate because 90% of patients diagnosed with lung cancer in Malaysia are still at stage 3 and 4. Only 3% are in stage 1. And the rest are in stage 2. So we all go home today knowing that lung cancer does not discriminate, can affect women. And if we have that in mind, then I think it will be an easier shift for us to seek treatment when we are not well. I don't think anyone should be judged for seeking treatment, and the x-ray turns out normal. But I think it's doing the right thing. Get it done and, get your fears allayed.
Thank you. Dr.
Yeah, I think it's important, Dr. Jennifer is right. It's important to not just advocate for yourself, the women in your life, but also for yourself. If you think you have symptoms and just go get you checked out. There's no harm, even if it turns out negative. Because if you get screened negative 1 year, it doesn't mean that, you'll be fine the subsequent years. So that's an important thing to keep in mind.
Right.
Very little to add. I echo what both my colleagues have said. I think the take-home message certainly is it's no longer just a male smoker's disease. So unfortunately, a lot of non-smokers, never smokers are being affected, predominantly women. So if you think you're at risk, either from a family history perspective or you're exposed to secondhand smoke, which is difficult to quantify, then explore getting screened. And yes, as a society, we have to be more inclusive and less judgmental. We have to try and destigmatize lung cancer. It's irrelevant. We ask patients whether they smoke or not. That's important for other reasons, but it's irrelevant in terms of the care they receive. And it doesn't matter, to be honest, whether you're a man or a woman or a smoker or non-smoker. It's a human life, and we should treat everyone fairly, and appropriately.
Great. I think maybe I can add one thing. Like, I think it's equally important for us as a society to normalize these conversations. Maybe in your next check-in with your friends, do ask them when was their last diagnosis, when was their last annual checkup, whether it was for lung cancer, breast cancer, but asking each other whether they have actually done a diagnosis or a screening in the past. I think we need to start taking a more active conversational topic around this space. And then for all those smokers, maybe one more reason to stop smoking is that your passive smoking or your spouse that is not smoking does have a much higher risk for lung cancer. But on that note, like I said, there is a lot of hope that you guys have shared today, and hopefully more women can be diagnosed earlier, screened earlier, and get treated with the right treatments, because if they do, then they can live longer and live better and be more productive in the system. So on that note, thank you so much for joining us today. And hopefully this breath of fresh hope has given you enough energy to go back and enjoy the non-polluted air that we have outside in Malaysia today. So enjoy, and thanks for joining us today. Over to you.
Thank you so much.
Thank you.
Thank you, Dipti. Thank you to all of our panel speakers. Now I'd like to close the event, especially for our live stream viewers. A big thank you, and hope all of you found the session inspiring. And just remember the take-home messages from all of our panel members, because it's important for us to remember the key messages here. Yeah? So thank you to all of the live stream viewers. I'd like to hold it to a close. To all of our live audience, I would like you to stay back for a bit because we're going to have a group photography picture. So just some pictures the media would like to take.